Welcome this afternoon. We are here with Ultimate Opinions in Medicine at our lung tumor board. My name is Mark Sosinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I'm joined by my four panelists. I'm going to have them introduce themselves. I'm going to start with Dr. West.
Hi, I'm Dr. Jack West. I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
Hi there, I'm Kristen Higgins. I'm a radiation oncologist at Winship Cancer Institute of Emory University in Atlanta, Georgia. I specialize in thoracic malignancies, and I'm an associate professor and could be here discussing cases with everybody.
Hi, I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I also serve as a professor in the department and the program director for our cardiothoracic surgery residency program. Glad to be here.
Hi, I'm Michelle Ginsberg. I'm director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center in New York City. I'm also vice chair of education in our department and professor of radiology at Weill Cornell Medical College in New York.
She's 60 years old, Middle Eastern heritage, non-smoker. She has a history of stage 4 adenocarcinoma, we're told, of the right lung. She's received several lines of treatment and progressed on those lines of treatment: erlotinib, osimertinib, carboplatin, pemetrexed, vinorelbine, and docetaxel. Now on vinorelbine again. PD-L1 negative, and her mutation is an exon 19 deletion. So we'll talk about what the options are for these patients. Again, she presented with cough and shortness of breath. We're told her ECOG performance status is a 1. She has no prior medical history of any sort, no family history. I mentioned before that she was a never smoker. I'll call on Dr. Ginsberg to review the radiograph in imaging on this slide.
And we see that there's a 3 by 2.5 centimeter spiculated mass in the right lower lobe. There were no additional nodules. There is a trace right pleural effusion, and there was no associated lymphadenopathy. PET-CT, which was obtained a month after this, which we don't have the imaging, did show that the effusion had increased and was now large. And there was actually a mediastinal shift to the left from this effusion, and the right lower lobe mass persisted. And the EBUS demonstrated adenocarcinoma consistent with the lung, metastatic consistent with the lung primary.
Yeah, we see here some information from a Foundation 1 report. She's microsatellite stable, has a very low tumor mutation burden, which is typical of these patients, PD-L1 negative. And again, as I mentioned before, she has an exon 19 deletion mutation noted in EGFR. So to summarize her systemic treatment here, she was initially treated with erlotinib, got the typical time to progression, about a year. We're not told anything about T790M, but she had osimertinib next, and then progressed after 6 months, transitioned to chemotherapy for 4 cycles with maintenance for 4 further cycles, then progressed, transitioned to vinorelbine. There were some issues with the drug availability, so transitioned to docetaxel, unfortunately progressed after 5 cycles, and then restarted vinorelbine. And we're told that the treatment is ongoing since March of 2021, so a couple of months here. And then, Dr. Ginsberg, I don't think you have these images, right? But we're told that these suggest progression.
Correct. They weren't submitted, but yes, that does suggest that there is progression. Assuming it's the effusion that increased, and but there was no mention of other lesions, I think.
Well, Dr. West, I'll call on you to help us kind of think through this case. This is not too much of an atypical case in this setting, but you know, what are your thoughts for next best option for this patient from a therapeutic point of view?
I would say it's getting more challenging as she has already received nearly all of the evidence-based choices that have an efficacy benefit. I think it's reasonable to try the vinorelbine. She never really had a chance with that because that was limited by the practical issues of just not having the drug available, more than she didn't explicitly progress on it. But her cancer has progressed on several prior chemo regimens, and I wouldn't pin a lot of hope on vinorelbine, at least helping for more than perhaps stability, or it would be gratifying to see any shrinkage on her next scan. But any time preserved with vinorelbine is great. Beyond that, I think my leading recommendation, I would be interested in your thoughts too, and I suspect we might both be thinking that this is a setting where we would hope to find something based on targeted therapy, acquired resistance directions. So if it's feasible to obtain a biopsy of an area of progressing disease, great, tissue would be very welcome. Otherwise, doing a plasma-based test could also possibly show if there's MET or some other secondary mutation that could point to a target. I think that she hasn't had immunotherapy, and technically that could be an option. I just wouldn't have a lot of hope. We've been pretty disappointed with immunotherapy, especially as monotherapy, in patients whose tumor harbors a driver mutation, including EGFR. Hers is PD-L1 0, TMB is 0. So I just think I wouldn't have as much enthusiasm, would offer that at some point just because you never know. But I would be more sanguine about a clinical trial if there is something available. Some of the drugs like patritumab deruxtecan and amivantamab, which was just approved in a different setting for exon 20 EGFR mutations, but could be potentially obtained, maybe in combination with osimertinib. But the data combining amivantamab with lazertinib in a clinical trial after osimertinib look encouraging. And I think that kind of approach, if a clinical trial could be pursued, to me is the leading opportunity.
Yeah, the question I was going to ask you first, Dr. West, was, is this a setting where you routinely do retesting? And it sounds like that's what you would favor, looking potentially for a direction. You may not find one, but you've mentioned, we've seen unusual bypass tracks, RET fusions and other things that might be targetable. It's not very common, obviously, but you mentioned MET amplification as a potential strategy in this population.
Yeah, and I would underscore that it's not a clear standard of care, at least in patients who get upfront osimertinib. It's not as if we've shown prospectively that leads us to better outcomes with broad testing and acquired resistance. But as the opportunities and the data paths are narrowing, I think that is a leading consideration. So I would just not go so far as to say it's a clear standard of care, but I think the potential upside is very real and the downside's quite low, particularly after we've exhausted many of the other options.
Another question I have for you, is there ever an opportunity or consideration for going back to a TKI?
There always is. I just would say that it tends to be pretty low yield. I think that it's more often done as a don't just stand there, do something. That if you get a response, it's usually measured in weeks that you could count on the fingers of one hand. It's not something that I would expect after a cancer has progressed on osimertinib as the second EGFR TKI I think the best opportunity, I think, is just from the TKI-free interval, but that tends to be short-lived. I don't know if your experience is better. Certainly, there are not good data to speak to this, and I think there are not good data in part because anecdotally, it's a bunt single at best.
Yeah, I would agree with that. I think we do that. I think the attractiveness of it is that you should know within 4 to 6 weeks if you're making any headway in these patients, and if you're not, then you can move on. Let me ask you about this. Let me be offer up a radical idea, and that is, I mean, I completely agree with every comment you made about immunotherapy as monotherapy, but we do have data from IMpower 150 in this subset of patients that looks at the VEGF and PD-L1 interplay there. This lady hasn't seen a VEGF drug. Assuming that she's PS 0 to 1 and she's robust and she is young, she's 60. Any role for an IMpower 150 sort of approach?
I think that's something that could be tried. I think honestly, just at this point, once all the other options that are more evidence-based have been exhausted, I think it just comes down to you and the patient and answering to your own God on this. I think that there's just not great data. I would feel more hopeful about it if she hadn't already received several lines of prior chemotherapy, but sure, I mean, I don't think that that's pulling her away from necessarily anything more compelling, except maybe if she could go on a trial of lazertinib and amivantamab, or something specifically for patients whose cancer has developed acquired resistance. That to me would be better. I don't like reflexively saying go on a trial, because that's not available to everybody. But when many of the better conventional options off the shelf have been exhausted, I think sometimes it is the best option. Otherwise, sure, it's a reasonable consideration to maybe add bevacizumab to whatever chemo you'd be thinking of next.
Yeah, that my thought in thinking about this case, that was the one thing, assuming she has no contraindications to a drug like bevacizumab. We know that the EGFR pathway activation does activate VEGF. We know that from a number of trials that VEGF seems to play a role in this disease setting. And I agree with you. I think if you were to exercise the IMpower 150 regimen, it should have been done probably after her osimertinib, when she had first failed TKIs, because that's where the data exists. Now that she's had several lines of other chemotherapies, it's a little unclear, but we always have a saying, you bet with the patient. And if she were robust enough, I would be interested in, less so interested in immunomonotherapy, but really using IMpower 150 as a way to get her the VEGF, the PD-L1 treatment together.
And I agree that though I do feel everyone should get their chance with immunotherapy, because you never know with an individual patient. We don't know everything there is to know about it. I am considerably less enthusiastic about it as monotherapy than if it were combined with something else.
Something else, yeah. So I think we've summarized this report. I do echo your comments about a clinical trial. I think if available, that would be pertinent. And then you mentioned the patritumab deruxtecan data as well as amivantamab data. We know amivantamab was recently approved, I think just yesterday, for EGFR exon 20 insertions, not necessarily for this type of EGFR mutation, but certainly some optimism, some hope down the road for these patients. So to summarize, in this heavily pretreated patients, if there were a clinical trial, we would we would prefer that. We know that there was some discussion about trying to integrate anti-VEGF therapy, perhaps in combination with IO-based therapy. Some discussion for retesting to see if that would be informative, realizing that probably most of the time it might not, but it might give you a lead in terms of what the next therapeutic option may be for this particular patient.